Did you know that knee pain affects roughly 25% of the American adult population and accounts for 4 million primary care visits annually? In this episode, it's going to be all about the knee, and we're going to cover everything ranging from the anatomy of the knee, common injuries that we see, and what an effective and proper physical therapy and rehab program looks like. Let's start off with some of the basics. Before we need to know what injuries can happen and what we're going to do about them, we need to know what we're actually working with when it comes to the structure of the knee. When we look at the knee, there are 4 main bones that we need to be familiar with. Our femur, or our thigh bone, our tibia and fibula, which make up the lower part of the leg, or our shin, and our patella, also known as the kneecap. Sandwiched in between the tibia and the femur is some important cartilage that we need to be made aware of, and this is our meniscus. And we have 2 different menisci that are referred to as the medial and the lateral meniscus. The meniscus act as a shock absorber and play a large role in comfort and fluidity of motion with tasks. It's very common for this meniscus and the associated cartilage to get worn down over time or with specific trauma from injuries. Now, if we know that the cartilage acts as the shock absorber for the knee, then we need to be aware of something called ligaments. And in the knee, there are 4 primary ligaments that serve a role of providing stability. Ligaments connect bone to bone, and they help provide a stable structure and foundation for us to perform movement off of. The common ligaments that you'll hear when referring to the knee are the ACL, the PCL, the MCL, and the LCL. The ACL and PCL form a cross. That's why they're called the cruciate ligaments. One running from the front of the femur to the back of the tibia, and the other running from the back of the femur to the front of the tibia. These provide stability with front to back and rotational motions. Our MCL and LCL are on the medial and lateral side of the knees, or the inside and the outside of the knee. These are stressed mostly with motions that happen side to side, so they'll refer to that as varus or valgus stress. The knee is a hinge joint, meaning it's primarily made to flex and extend. It has a minimal amount of rotation and a small amount of side-to-side movement, but it primarily functions just as a hinge moving in one plane of motion. These ligaments get stressed when we move in extreme positions or we have too much side-to-side or too much rotational demands. In addition to bones, cartilage, and ligaments, there are also some very large muscles in this area that we need to talk about if we really want to appreciate the knee and its structure. On the front side of the thigh, we have our quadricep muscles. The quadricep sits on the front part of the thigh, and the quadricep tendon attaches to our kneecap. On the other side of the kneecap, we have our patella tendon, which runs from the kneecap to the tibial tuberosity, which is really just the bone on the top part of your shin. This muscle and tendon complex is what's responsible for extending or straightening the leg. On the back side of the thigh is where our hamstring muscles attach, and we have 3 different hamstring muscles which connect to the outside and the inside portion of the knee. They work in opposition to the quadriceps. They work primarily with knee flexion or bending the knee. As we go lower down, we get into the calf. And in the calf, we have 2 muscles that serve a primary motion with activities that we do from a daily living and from a sport and athletic standpoint, but they also can contribute to how the knee functions, and this is the gastrocnemius and the soleus muscle. Both of these muscles primarily act to plantar flex or point our toes. So if you think about raising your heels off the ground, coming up onto the balls of your feet, those are the muscles that allow for that to happen. These muscles attach high up into the calf, right behind the knee, so they also play a small role in knee flexion and also our ability to fully straighten our knee if either one of those muscles is too tight. When we look at the knee, I always say it's kind of like the odd one out in the lower extremity. we have an ankle, a knee, and a hip joint. The ankle joint and the hip joint can provide a variety of motions. They can flex and extend or move front to back. They can ab and adduct or move side to side. And they have large rotational or circular motions that they can do. While the knee, like we mentioned, is primarily a hinge joint. So while the quadriceps, the hamstring, and the calf muscles play a large role locally at the knee with how they produce movement and control stress and forces through the knee, our balance, stability, mobility, and strength, both at the muscles and the joints of the ankle and the hip, will also play a large role mechanically with how the knee functions, our overall health, and performance with athletic activities. Now that we know the structure and the anatomy of the knee, now is the realization that sometimes pieces fall apart and sometimes pieces break. So all of the different parts and pieces we just talked about, they have some associated injuries that can take place with them as well. The bones that we mentioned, the femur, the tibia, the fibula, and the patella, they can be vulnerable to fractures or broken bones. And these really come in two main forms. We can have a more traumatic fracture, where you think of your traditional broken bone, where the bone is broken into two pieces, and that has often happened with a high level of impact or trauma. So you can think about being in a car accident or falling from a large height, or having another object or person run into you with a great deal of force, like in an athletic event. You can also have stress fractures, and these are not as traumatic and they are not as dramatic in how they occur. They're often due to repetitive stress. So think about somebody that is doing a highly repetitive activity such as running, but they're not taking care of themselves with regards to recovery. Maybe they're not getting adequate sleep or adequate nutrition, or they had an abnormally high amount of exercise activity compared to what they're used to, and it was too much for the bone to handle. That would be something that is more of a stress reaction and can progress to a stress fracture. We also mentioned that there is cartilage within the knee joint, and it's important to delineate two different types of cartilage. We have our articular cartilage, which is actually the lining of the joint surface, and we also have our meniscus, which is that cartilage that is in between the two bones that acts as the shock absorber. The cartilage, whether articular or the meniscus cartilage, can both be injured in two main ways. One can be just a progressive degenerative nature, or your common wear and tear that happens over time. From being on your feet, being active, maybe doing strenuous occupations or careers or just daily activities, eventually those parts and pieces can take on stress and begin to wear out over time. The other way that cartilage can be impacted or injured is through more traumatic means. Oftentimes when we're talking about athletic events, this happens when we are doing high amounts of pivoting, cutting, rotation, or contact with another individual. Our ligaments, and those were the ACL, PCL, MCL, and LCL, those are often injured when we find ourselves in a very strenuous environment from the amount of force that we are being asked to absorb or produce, or when we find ourselves in a compromised position, meaning that we're in a non-traditional or kind of an awkward position, or our joint is at the very limits as to how far it can move or how far it can stress. I always refer to ligaments kind of as the emergency brakes of the body. When we're moving, when we're running, as we're speeding up and slowing down, our muscles are what's responsible for producing that movement and slowing down that movement. If we do an activity that's beyond what our muscles can control, oftentimes that stress gets translated over to the ligaments. Eventually, if we do that too many times, those emergency brakes are going to go out. Just like a ligament, if you find yourself in a compromised position or with too much force or too much stress in that position, you can suffer a ligamentous injury. Now, ligaments come in three different grades with regards to how much you can injure them. Grade 1, 2, or 3. 1 being the least severe, 3 being the most severe. 3 refers to a ligament that has been completely ruptured or completely torn. With this, there is no chance for that ligament to heal, and we often are looking at surgery to intervene and correct the injury. Grade 1 is the exact opposite. It means that that ligament has been stretched, but it is still structurally intact. With this, there is often less pain, there is often less swelling and less bruising, and overall your functionality with regards to your range of motion, strength, and ability to do daily activities is limited, but it is not as significant as a grade 2 injury, which is kind of that in between of the 1 and 3, where we have stretched the ligament and we have created some damage to the ligamentous fibers, but they are still intact and not completely torn. So you can refer to this as a partial tear. Grade 3 often requires surgical intervention or a significant modification of what activities you're going to do. Grade 1 will typically heal on its own with some guided rehab. Grade 2 is kind of that in between. It is able to continue to function without going for surgery, but it will take a longer amount of time to heal and a longer amount of time for your swelling, bruising, and pain levels to go down, in addition to restoring your range of motion, your strength, and returning to activity. When we've had a grade 2 injury and even a grade 1 injury, we need to make sure that if we are returning to our previous activity or our previous sport of choice, we're in a manner that is safe to do so, so that we're not putting ourselves at elevated risk for re-injury or further complications down the road. The last injury that we'll talk about are injuries to the muscles and tendons. And muscles, oftentimes you'll hear this as a muscle strain or a pulled muscle. They come in all varieties of severity, just like our ligamentous injuries. We grade them the same way, 1 through 3, 3 being the most severe, a completely torn muscle, 1 being more of just a small pull or a tweak, and then grade 2 being in between. The prognosis and how you go about treating them is very similar to the thought process with regards to how you treat a grade 1, 2, or 3 ligamentous injury. A tendon, which is the area that connects the muscle to the bone, can also be injured with activity. And we'll often refer to this as tendinitis or tendinopathy. Tendinitis refers to just a general inflammation of the tendon, while tendinopathy refers to a more general or broad irritation and aggravation of that tendon. Tendon-related injuries are usually due to changes in activity, so starting something that you have not performed before, attempting an activity at a higher frequency, volume, or intensity than what you're used to doing. So think about an individual that usually runs twice a week and they decide to run 5 days a week. They're putting an abnormal amount of stress on tissue that's not really acclimated or used to it, or somebody that has always done something at a more recreational level or a lower intensity, and they've ramped up to a higher intensity or a higher competition level, and they did that in a relatively quick manner. If you find yourself in one of those situations, you may suffer from tendinitis or tendinopathy.